Good morning. My name is Tracy Trypuc. Welcome to Your Health Matters. All this week, the nation has joined together in this important conversation about National Suicide Prevention, an annual week-long campaign in the United States to inform and engage health professionals and the general public about suicide prevention and warning signs of suicide. This week also coincided with World Suicide Prevention Day, which occurred this Wednesday, September 10th. Before I introduce our guests, I'd like to share some important information. In 2010, there were 38,364 suicides, according to the CDC, an average of 105 a day. Currently, suicide is the 10th leading cause of death in the United States for all ages. A person dies by suicide about every 15 minutes in the United States. An attempt is made about once every minute. While we are producing this show, 2 persons may have died from suicide, and 30 persons may have made a suicide attempt. 90% of all people who die by suicide have a diagnosable psychiatric disorder at the time of their death. There are more than 4 male suicides for every female suicide, but 3 times as many females attempt suicide than males. Suicide is the 5th leading cause of death among those aged 5 to 14, and it is the 3rd leading cause of death among all those 15 to 24 years old. Among young people aged 10 to 14, the rate has doubled in the last 2 decades. Suicide rates for men rise with age, most significantly after 65. And the suicide rates for women peak between the ages of 45 to 64 and again after 75. Some risk factors for youth include suicidal thoughts, psychiatric disorders, impulsive aggressive behavior, drug and/or alcohol abuse, previous suicide attempts with increased situational stress, and access to firearms. And risk factors for older people include presence of a mental illness, depression, alcohol use, presence of a physical illness, social isolation, being widowed, and the availability of firearms in the home. There are also some racial and ethnic disparities, which I will have my guests speak about. But first, I would like to welcome my guests. Today we have with us in the studio Dr. Mansour Max Banilivy, a noted clinical psychologist who specializes in suicide prevention and assistant director at Pederson-Krag Center. And with us by phone from Florida, we have Michael Stoltz, a licensed clinical social worker and CEO of the Clubhouse of Suffolk Mental Association in Suffolk and Suffolk County United Veterans. Thank you, gentlemen, for joining me.
Good morning. Thank you.
Dr. Banilivy, do you have any comments to add to my introduction?
You did a very good job. We wanted to say that indeed those numbers are gross underestimations, of course. We know that number of people who die by suicide are larger than what
Yes.
we CDC can report, and people who attempt, there are many more who attempt. And we also want everyone to know that suicide happens in every community, in any group, and it doesn't discriminate. And thinking about suicide is much more common than people realize.
Yes. Michael, would you like to add anything?
I think Dr. Banilivy is absolutely correct. Most often we find out more about suicide from the investigations after the death by going through interviews with families and such to really determine that suicide was the cause of death. I'll tell you just one other piece in terms of your data. There has been pieces in the news lately about, and some of it was associated with Robin Williams' death, is that there's been a fairly dramatic increase in suicide, completed suicides among men between the ages of 35 and 64, that it's gone up almost 50% over the past 10 years.
Yes, I appreciate you bringing that up. And I did want to ask you about the tragic death of Robin Williams. You wrote an op-ed piece in Newsday on August 12th, 2014, regarding that unfortunate tragedy. And in the article you describe that, quote, lying beneath the humor and mimicry was profound sadness and human pain, and that hopefully, as a society, we will insist on getting uncomplicated and affordable access to treatment, increased peer support, and a greater understanding and acceptance between mental health and physical health. Would you like to elaborate, please, on that?
Well, the first part of this is to understand there's so much stigma associated with mental illness, and in fact, there's a connection between suicide attempts and the sense of shame and despair and embarrassment about human pain. And that was really what I wanted to write about, is that emotional pain is akin to physical pain in terms of the damage that it can inflict and the risks that exist. In terms of things that we can do better, I think there is still a disparity in terms of access to mental health care as compared with access to physical health care. And hopefully, certainly the Affordable Care Act and all the plans on the exchanges and such included a mental health benefit because of past successful parity legislation. But we still have work to do in terms of making sure that people who need help get to help, and in terms of making sure there's an adequate capacity of mental health slots availability in the community, whether it's private or through our publicly funded clinics.
Okay, yes. And before you respond, Dr. Banilivy, I do want to assure our viewers that at the end of the show, we will be putting up some hotline numbers and some websites that you can have access to in case you or a family member or loved one, need to access those numbers in need of assistance. So, Dr. Banilivy, would you like to respond?
Absolutely. We just wanted to highlight that I think what we want the audience to know that 1 out of every 20 people at any one time in a 2-week period of time could think about suicide. So thinking about suicide is a common phenomenon. Thinking about suicide, it doesn't mean that the person is necessarily very serious, is going to take their life at that time, but it means that there are circumstances in their life that they're having a hard time dealing with. And going back to what Mike said, we would like to have people think of suicide as a form of pain management and as a way out to manage their pain. So we would like to really look at it more positively, to say that if we can help people with their pain and circumstances, indeed we can go a long way in terms of saving lives. On the unfortunate negative side, we know because of the rise in terms of incidence of suicides among veterans, as well as the economy, we've seen a rise in number of suicides. However, New York State and Long Island in particular have been very progressive in terms of efforts to put many steps in creating a website and having many resources available that previously were not, and helping the community and the region in general be able to access expertise as well as resources, as well as trainings and education that only a few years back was not available here. So as much as there's a tremendous amount of stigma still, and we could spend probably hours and hours talking about why the stigmas still exist in 2014. And the stigmas had to do a great deal about misunderstandings, misinformation. So there are many, many myths now that we have started to eat away at, to eradicate those. So those people who indeed are suffering with that kind of a pain, with that kind of a thought process, would feel about seeking resources the same as if they had a headache and they wanted to go to their primary care physician.
Right. Could you dispel one of those myths right here with regard to people saying that they're afraid to actually broach the subject about suicide with someone who they think is suicidal because they think that that's going to push them to actually commit?
This is probably one of the better ones you could pick because particularly with youth that we know about during the course of the high school, one out of 4 high school students may think about suicide, and we know many, many professionals are very, very concerned about even approaching the subject with youth, but for that matter, with anyone to bring it up. That's one of the myths that we know that is not true at all, and that is asking people, and particularly asking people directly about suicide, does not plant the seed. People are no more likely to do anything about it than they would be if you ask them to give you all the money they have in their savings account. So we know that asking people directly about suicide, in fact, helps. And we need to ask ourselves the question as to what are the people who are thinking about suicide they're actually looking for from us. And we're finding out that they're really looking for us to be approaching them, asking them about their thoughts, and whether they indeed have had those thoughts in the past.
And can you provide them with help?
Right, we can provide them, and we know hopefully through your program today and some of the resources you're going to provide, they're going to know that if they have had those thoughts and they are thinking about it, there are people and places they can actually call and find out information about it, as well as get the kind of help they need.
Okay. First to you and then to Michael. I see that suicide prevention is organized into 3 strategies, the suicide prevention and then intervention and then postvention. Could you briefly describe the different strategies?
I'll be happy to. First of all, I want to work backwards in saying we'll look at postvention as prevention. That is not just by prevention we mean to provide gatekeeper training, education, and awareness, like September 10th, which is the World Suicide Prevention Day, and this week is the National Suicide Prevention Day, as a way of bringing attention to it and educating people as to what suicidal thinking is and is not, and making people aware and giving them resources. But at the same time trying to educate gatekeepers and stakeholders in the community to get better educated about and have an awareness and alertness about those who may have thoughts of suicide. Intervention has more to do with what do you do with an individual who's seriously thinking about suicide, or even they may not be thinking about suicide because the thought may have crossed their mind. And those are having to do with the resources we already have in the community. Postvention having to do with the work you do after, sadly, a suicide happens, and how do you help people grieve and heal, but at the same time, what are the steps to take in order to prevent suicides in the future and reduce them?
Okay. Michael, would you like to add anything to those strategies?
I think Dr. Banilivy did a wonderful job explaining those aspects of suicide. I would just make just having a vision in terms of post an attempt. Almost 20% of people who complete suicide have attempted suicide previously, and in terms of work that we had we would like to see happen is kind of better handoffs from hospitalization admissions or emergency room visits into care. That people who tend to get care for depression, for other mental health disorders, and for suicide attempts, the risk of suicide attempts reduces dramatically when they're in care. Unfortunately, our system of mental health care is still evolving. We don't have the strong handoffs from hospital to community care, and then to be diligent in ongoing kind of monitoring and support. As I wrote about, peer support is most important for people who have been through depression and mental health challenges and substance abuse before. That is when the risk factors are highest, is after people have made an attempt, and we can do better in terms of helping to reduce the risk.
So continuity of care among health professionals and within the community and the family then would be very important. Okay. Could you, Michael, could you give us just a few warning signs that a person is depressed and maybe thinking of suicide?
Sure. Tends to be the distinction between, if you say, things that people talk about and the way that people behave. So people who are thinking about, as Dr. Banilivy said, and a large percentage of people almost at any one time, or have thoughts about hurting themselves or taking their life. People talk about hurting themselves, talk about having no reason to live, being a burden to others, having anger, seeking revenge for things that have happened to them, or feeling trapped, or having unbearable pain. Those would be things that people might talk about. And then we also look at actions, at behaviors. So behaviors might be an increased use of alcohol or drugs, trying to find ways to hurt themselves, like searching online to find information about taking your own life, or methods. Withdrawal is a significant sign. Changes in sleep, changes in eating and appetite, more risk-taking, giving away possessions. Those might be the kinds of behaviors. So when we think of warning signs, we think of what people say, and we think of how people act.
Okay. Dr. Banilivy, tell our viewers of some resources that are available in times of crisis.
It's certainly the response of Suffolk County as an example. In terms of, I'm going to focus on some of the local things that exist at this point, which people can access very easily. A lot of people in the privacy of their homes, we have developed a website, preventsuicideli.org, which I think you're going to show your audience. Yes. I would strongly urge everyone to go and just browse. We have a tremendous resource there that people can download, the information that they can have, where to call certain agencies, including Pederson-Krag and other agencies in Suffolk and Nassau that they can contact. There are a number of crisis hotlines. You're going to be listing them that they can access. Most importantly, that anyone among your audience who has thought about it, who is thinking about it, and is going through a difficult time, they should just simply tell somebody about it. We want to mention, most importantly, that we don't consider suicide just a mental health issue. We consider it a public health issue. And as such, we want everybody to know, and that's why we focus so much on training everyone in the community, gatekeepers and stakeholders, not just mental health professionals, to be alert to the signs and know how to interface with individuals who have suicidal thinking.
Well, for both you and for Michael, and Michael, you can go first here. How important is the family in a time like this, as far as support or other support systems, and does a family actually, can they pick up on these signs, or do they know when to seek help? I mean,
Let me just, if I could, just take a liberty here and step back to community resources, because part of my my agency is devoted to at-risk veterans, and I'll dovetail into your question about families. But it's been pretty well documented about the increase in suicides among veterans, and as you're giving out the hotline information, there is a veterans crisis line at 1-800-273-8255, and this is important partly because related to your question, we have a project under our umbrella called the Joseph P. Dwyer Veterans Peer Support Project, and our staff is all veterans who are intimately experienced with mental health challenges and transition challenges among people who are former military. Our calls, going to your question, predominantly come from family members who find out about our resources. And I'm particularly talking about our veterans here, but I would say also many other crisis lines. The calls come from family members who say, what is it that I can do because I see the following or I hear the following from my loved one. So I'll say that there's wonderful peer, family-to-family support in the community, also through the National Alliance of the Mentally Ill and mental health associations like ours always run family groups to help family members to deal with crisis situations, prepare for crisis situations, be able to ask the kinds of questions of their loved ones that, as Dr. Banilivy spoke about, are hard sometimes to ask, but important to ask, and then to be able to help people to access care. Families are often the first line of defense.
Mm-hmm. Okay. Okay, so we are about to wrap up, so I would like to come back to this question then, since we've already spoken about postvention and the bereavement, and the websites will be up as well as the hotline numbers. But you've alluded to this, and I just would really like to come back and ask again. What do you see as like the biggest, or the one or two of the biggest needs to help patients in this time of crisis, and to help reduce the rate of deaths by suicide? And what have we, here in the United States, what have we missed with regard to helping people who desperately need our help?
Well, it's a question that may take us more than a couple of minutes to answer. But try to...
The disconnect, is it one of the
I think the
disconnect we're
disconnect there are many different issues. One is that we have, until very recently, we didn't really have good training, even for the clinicians, in terms of the comfort and skill base to be able to work with those individuals who have suicidal thinking. We're getting better and better at it. I think the stigma, and getting rid of the myth and stigmas, and getting people to talk about it more, it will help a tremendous number of people in terms of helping them. I think not being afraid of talking about it is a big part of it. Not thinking just that this is just always means death, and just referring them to the emergency room and hospital. Those are great resources. However, they don't provide the long-term treatment that the individuals need. So we need to really look at multi-system level. We need to look at the gatekeepers and stakeholders. We need to do education. We need to do public health education. We need to do clinical training for those who are in the mental health field. We need to educate everyone, and we need to educate public and families and all entities in the community about being more sensitive. That, and most importantly, the message is, although people may have thoughts of suicide and be in pain, most often they only want to kill the part of them that is in pain. And so there's always hope there. So that anybody concerned should just pick up the phone and call someone and say, somebody's in distress, what can we do about it?
Right. Michael, last word?
I would just accentuate something that Dr. B said, which is the relationship. One place that I'm most optimistic about positive change going on is the relationship between physical health care and behavioral or mental health care. And there's research that supports that, recognize depression, be able to ask the question about suicide risk, and be able to make really quick and easy linkages to behavioral health care. So we're seeing a lot of change starting to happen in our physical health and behavioral health systems that are going to improve and kind of reduce that gap.
Okay. Well, thank you. Thank you, Dr. Banilivy and Michael Stoltz, for speaking with us today about this very important topic of suicide prevention. Please tune in next week for another Your Health Matters with Tracy Trypuc. I am hoping to have a special guest on the show to discuss this enterovirus D68 that is sending so many children to the hospital. Thank you, and I wish you a safe and healthy day.
Thank you.
Thank you. Thank you, Michael.